Good afternoon and welcome back to the last episode of this 6 session long lecture series called Wrangling 360. In today's session, we are going to talk about the standardizing of the delivery, the concerns related to safety, concerns related to the effectiveness of dry needling. One of the prime concerns from the patients and from other therapists as well as other people of the medical fraternity is that is dry needling safe and is dry needling effective. So we should put ourselves through that thorough scrutiny and we should come clean in that, in at least creating an uniform structure of needling. So this had been the course Dry Needling 360, where we had 5 online lectures so far, and this is the 6th one. And how it worked is we had gone through all the online lectures. I hope all of you who are present have gone through all the online lectures. And before that, in the WhatsApp groups that I had created specifically for this course, I had posted the pre-reading material. After going through that material, if you attend these lectures, then you'll also be able to attend the quizzes which are given also in the links of the quizzes have been given in the WhatsApp groups. And as you answer the quizzes, you must have already got 5 certificates. If not, you can go back and you can take them today or anytime. And then after today's session, you'll get the 6th certificate and 6th MCQ. And then after 2 days, that is on Sunday, I will post one more, a longer quiz, which is also going to give you a course completion certificate. So this is how the system has been created. And if you have missed any of the lectures, then you can always come back to YouTube, observe or view those lectures. And as you view those lectures, you afterwards can take the quiz anytime. The links will be open, the website will be open, and you can take this course anytime you want. This is where we are at the end. The red color marks the end of the course. Today we will finish it, dry needling, standardizing the delivery. So while we talk about standard of safety and uniformity, to keep the things easy and streamlined and simple, I had created this acronym called SPIDER. Now each letter of this word spider stands for something. S is for surface anatomy, P is for the position of the patient as well as position of the needle, I is for incidence angle. Incidence angle is the angle at which the needle is entering into the body. I have kind of borrowed this word from physics, law of reflection, refraction. And then D is for depth of target tissue, E is to educate the patient, R is to record the session. Now, why do you need the safety and standardization and all this spider and this kind of streamlining? Is because dry needling has specific risks. Sometimes they are life threatening and sometimes they create long term morbidity. You and I should not be harming the patient in the process of needling them, and that is why there is a need of proper safety and standardization. And then it also has to be a quality treatment and effective treatment of the condition, and that is another need. Now, to be fair, there are specific guidelines in many places, whether you call it whether you look at APTA or you look at other spheres where dry needling is practiced. I have tried to collect best from them and I have tried to put it in a easily digestible, easily utilizable form, which is a dry needling assessment form. We will discuss that in a while. So coming to spider, S is for surface anatomy, as we have seen. Why do you need to understand surface anatomy? Is because otherwise, if we do not understand that what is the surface anatomy of the structure, will not be able to isolate specific structure, will not even be able to identify them. So will be someone like this person who is shooting bullets indiscriminately in a random fashion. That should not happen when you are dealing with something as sensitive as dry needling. You should be able to specifically target the target tissue, and you should be able to isolate the tissues that are vulnerable. And that is why surface anatomy is of extreme importance. Unfortunately, in many of the universities where I have taught in 5 universities, uh, one part-time in 6 university. So in my last 12 years of academic career, in nowhere I find more emphasis on surface anatomy. Now, when we are studying surface anatomy, we must know what is the normal anatomy. For example, one of the major risks of dry needling is pneumothorax, and we should know that where the pleura is present so that we can avoid the pleura. The textbook says that medial one-third of the lung, up to 2 inches above the medial one-third, there is pleura. Similarly, another area where you often needle is the paraspinal area, where the the area of pleura starts about on the lateral border of the sacrospinalis muscle. However, there are other vulnerable anatomical structures and you must know them. So if possible, give my channel subscribe. You will get all these videos where I have talked about the surface anatomy of femoral artery, femoral nerve, femoral triangle. On the other hand, this side it is the surface anatomy of radial nerve, important for needling tennis elbow as well as your triceps and all of the structures. So you must know what are the vulnerable anatomical structures. So someone asked me yesterday in the chat box after I finished the YouTube live that can you summarize the dry needling procedure in a gist or in a very uh, concise manner. So if you want to summarize the process of dry needling in a concise manner, the simple answer is you want to reach the target tissue with your needle. You want to avoid the vulnerable structures with your needle. So you must know what are the target tissue and what is the surface anatomy of them, and you must know what are the vulnerable structures and what is the surface anatomy of them. However, please understand that there is always deviations from the surface anatomy. This is one extreme case when this person is having a severe amount of scoliosis, and in this person you do not know where the lung ends, where the spine starts. Also, same thing can happen not in terms of lung but in terms of rest of the body part, wherever you have a malunion, wherever you have a body deformity. Also, that is why needling the little children means if you at all have to needle a child, you'll have to understand the anatomy better. Now, after surface anatomy, come to position of the patient and position of the needle. P is for the position of the patient and P is the position of the needle. Now, why do you need to concentrate on position of the patient and what are the considerations? We had discussed the difference it makes between lying position and standing upright position. We have seen that in lying position, the anti-gravity muscles are relaxed. On the other hand, in upright position, the anti-gravity muscles are contracted. For example, if I'm sitting or standing as I'm standing now, you want to needle my trapezius, you want to needle my quadriceps, the muscles will never relax because they are anti-gravity muscles and our reflexes, postural reflexes will keep them contracted. Of course, you will never needle a quadriceps in standing, you will never needle a gluteus maximus in standing. However, I have seen therapists and I've heard therapists who are needling the trapezius in sitting position. Best to avoid. Also, we have talked about the vasovagal attack. Many times, if you needle, there is a chance of getting a vasovagal attack, especially if the patient is anxious and especially if the patient is getting needled for the first time. So, in such a scenario, it is much easier and much more easily controllable if you are needling the patient in a lying position. On the other hand, if the patient is in upright position, in sitting position, and the patient is getting a vasovagal attack, the patient will fall. And I know of a patient where the therapist had needled the patient in trapezius in sitting position and the patient fainted, patient fell down. the needle which was in the trapezius had gone a little deeper, and the patient's therapist was more scared than the patient that if the needle would have gone to lung, what would have happened. Especially understand that this area above the clavicle, the supraclavicular area, is a little more vulnerable than the rest of the part of the pleura. Here the fascia is very thin, the Simpson's fascia is very thin. So it is much easier to puncture the pleura through the supraclavicular area compared to the other parts. Then when you're needling the patient's position is also important to decide whether the patient's muscle is in shortened position or is it lengthened position. It is always good to needle a patient in a comfortably shortened position. So that is why all the needles, like that is why all the structures that you want to needle has a preferred position. Now it is not something that you cannot, it is not something that you always have to abide by. You can make certain changes in these positions, but for example, if you're needling the calf muscle and you're putting the patient in complete prone line, then you understand because the knee is extended and the gastrocnemius is coming from the knee, the whole calf muscle will remain tight. It is much easier so to needle the patient in side line where the knee is a little bent, so that you have reduced the tone, the passive tension actually on the calf muscle. So that is why needling of every structure has a preferred position. But then as you increase your expertise, you can fiddle around, you can play around with their positions, and you can find what is best for your patient and what is best for you. So what is more safe for needling and what is comfortable for the needle for the patient. Then the third consideration is muscles move with position. So if you are trying to needle a patient, imagine in the lower trapezius in prone line, it will make a real difference if you keep the hands up versus hands on the side of the body. If you can do that to your patient, if you observe that in your patient, then you will see that as the patient keeps the hand on the side, the lower trapezius border is much down, and then as the patient lifts the hand and keeps it below the head like this, the scapulae rotate and the lower trapezius border goes up. So you will have to take care of all these details when you're taking account of the patient's position. Then the hand position of the needle position is also important. For example, when you're needling a muscle which is, in this case you are needling the rhomboids muscle, and you'll have to take care that you are avoiding the pleura. So how you are placing the patient's body and how you are placing the needle is of extreme importance. So what you can see here is the middle finger of the therapist, my hand actually, is on the upper intercostal space. The ring finger here is in the lower intercostal space, and this dotted line represents represents rib cage. So you have fixed the needle over the rib cage, and because you have the two fingers holding the needle together, there is no chance that the needle can slide up or down. Let me show it with a skeleton. So what you are trying to do is you are keeping one finger in the upper intercostal space, one finger in the lower intercostal space. So you are fixing the structure between two fingers and fixing the needle between the two fingers, and then you are inserting the needle here between your two fingers, and that is how it should be. Now imagine you feel that the structure you want to needle is in the intercostal space itself and it is not on the rib. then you will have to make considerations, you will have to make adjustments on the patient's body. So elevate the shoulder, depress the shoulder, elevate the hand, depress the hand, as in abduct, adduct, however you want, but you'll have to bring that painful structure, the structure that you want to needle, at the area that is overlying the rib. So that is also the importance of the position of the needle. So patient's position, needle's position, both are interdependent. So those, that is P. Now coming to I. I is the angle of incidence. At what angle the needle goes into the patient's body. Now the angle is of high importance. For example, when you're needling the trapezius, you know that you are going in the supraclavicular area. Now you, in the supraclavicular area, if you change the angle, then it will make the difference of going towards the lung or going away from lung. See this, the ideal direction of needle is how it is given in the static picture in the upper corner. That is, the direction of the needle should be lateral and should be either anterior to posterior or posterior to anterior in this case, because the patient is needling prone line, and the direction of the needle should be superior. So if you go superior and lateral, you are still piercing the trapezius muscle, but you are not going into the lung. On the other hand, in this picture, this is Troy. See how Achilles is inserting his needle onto this person, where the direction is, see, it is medial and it is inferior, just opposite of the proposed direction. So with the same entry point, because the incidence angle is different, you can create either analgesia or you can create a slow painful death. Of course, because his needle is so long, it will also go beyond pleura to the aorta maybe, and that is why the death is immediate. However, it is possible to kill a person by creating a big enough gap in pleura, especially through the supraclavicular area. If you try this, I am not responsible. So let me, it merits a further demonstration. So I'll just increase the size of the picture and I'll use the skeleton once again. Now if you observe this, if you observe this, from the same entry point here, I hope he doesn't mind, if this is the clavicle, from the same entry point here you can go laterally, it is posterior and lateral and superior, or from the same entry point you can come towards the rib cage. So same thing in the posterior side as well. If say from the spinous process you take one finger and you direct the needle towards the spinous process, you are going to the muscles which are paraspinals. However, if you direct the needle from the same entry point laterally, you are going to the pleura. So you should be taking care of these details if you decide to needle a patient, and it is not only related to the rib cage. Same thing can happen, same kind of problem can happen when you are needling a patient in other body parts as well. So if you are needling, for example, a patient around the head of the fibula, you should be staying away from the neck of the fibula, because the common peroneal nerve comes here. At least if your aim is not to needle the nerve, if you are deliberately needling the nerve, then you know what you are doing, and then you know what is the amount of poking you want to do. So that is about the angle. Now coming to the depth of the needle, how deep you should go. So this picture. Now if you are needling, say, the paraspinal muscle here, this So you have, in the surface you have got the first layer of muscle, which will be the muscles that is attaching to the scapula. Then you are going deeper to the paraspinal. Then if you continue to go deep and deep, you will go into the rib cage. So if you are needling the latissimus dorsi, if you aim, then you should not go too much deep. If you go deeper, then you will end up going into the serratus anterior. Further deep, you can go into the intercostals, and further deep, pleura. You may ask, in an area if there is no lung, then how would you, then also the depth is important or not? Yes, the depth is important because there are muscles in layers, and then there are other structures. For example, if you are needling, say, below the thoracic cage in the back, if you are needling superficial structures, you will be needling the rectus spinae. Then you can go deeper, then you will be needling the transversus spinalis. Then if you go further deep, you will probably end up needling the P and Q, the psoas major and quadratus lumborum. And if you venture further deep, then you will go into the peritoneum. So the needle depth is of umpteen importance. When we talked about the safety or the mechanisms of how to do safe needling, we said that when you are needling over the bone, then it is much safer. But again, we discussed that don't take the bone protection for granted, because not all bones are of same thickness and ossification. Many times membranous bones do not ossify completely, and that is why it is possible to go through the bone to the vulnerable tissue. So how do you take care of the problem of needle depth? One of the ways is to decide what size of needle you want, and the other way is to decide what angle of needle you want. So imagine this is your needle size. The same size you can pierce through 4 fingers, or if you can make an angle, then you can stay superficial even with the largest of the needle. If I give you an example, gluteus maximus, when you are needling, we know it is the most superficial muscle of the gluteal region. If you go vertically down, then you can pierce the gluteus maximus, go into piriformis, go into the sciatic nerve. However, if you can keep the angle at check, then even with a long needle, you can stay in the substance of gluteus maximus and not go into other structures where you don't want to go. The E of spider is educating the patient. What do you want to educate about? You want to educate the patient regarding the activity, what the patient should be doing and what the patient should not be doing right after needling. Why it is important? Because if you have attended the session where we talked about the contraindications and dangers, we said that people who have got pneumothorax get it after, say, 6 to 8 hours after needling. Why does this happen? This happens because once the needle is inserted to the pleura, like any other soft tissue of the body, it has got its own protective mechanism. Like the muscle and the skin kind of seals around the needle, once you take the needle out, the pleura also seals around the hole. However, after that you do heavy upper limb activity, you lift heavy weight, throw balls, play tennis, punch, swim, or do any other household work which involves a large range of motion, forceful upper limb activity. Even coughing, because that is why people who are having COPD or chest wall problem are more vulnerable to the pneumothorax. What happens is, it's like you have a hole in the fabric which is not visible, but if you pull the fabric multiple times, what is going to happen is the hole is going to be bigger and bigger. And that is why, if especially you have needled the patient, if you have needled the patient around the chest wall, then it is important for the patient to understand that the patient should not be doing heavy upper limb activity at least for 1 day. That also means that if you are needling a swimmer, a boxer, a javelin thrower, then you should be needling the patient after the day's practice, after the event, if you are needling around the chest wall. Of course, if that particular patient is having a hamstring problem, a groin problem, then you are free to needle before the practice, before the activity as well. Then regarding the recognition of symptom, it is very important, and we'll have to tell the patient if the patient is getting symptoms of pneumothorax, if the patient is getting symptoms of nerve damage, if the patient is getting a severe bruise, if the patient is getting any other problem. And then regarding decision making, because theoretically dry needling releases a lot of endorphin, in certain few cases those that can make the patient drowsy, that can meddle with the decision making process of the patient. In general, most of the patients you'll get to see after needling, if you ask them, they will say that they have had a nice good night's sleep. However, if the patient is, say, a strong responder and the patient is having a high amount of endorphin circulating in his bloodstream because of the needling, then the patient's decision making can be meddled with. Then R is for recording. And what do you want to record? You record the patient's treatment procedure, the whole of it. And to record it, I have come up with a assessment form called as dry needling assessment form. Now this is a novel form of assessment, but nothing out of ordinary. Actually, you can call it as plagiarism as well, because I had copied certain attributes from the McKinsey assessment form. I love the way it is structured, and I love the way it gives a standardization, so that I have taken inspiration from McKinsey assessment form and created this form, which is called as Wrangling assessment form. I'm also copyright holder of this form, so if you want to use it freely, but please don't tamper with it. To download this form, you can go to today's link of study material, and in that there is a download section, and you'll get a version of this form. If you have any more doubt, you are free to contact. Now let me explain the attributes of this form. How do you use this form, and what are the parts of this form? Because if you open this, there is a lot of text in this, and sometimes it may feel daunting. It is something that is very easily utilizable, and it has been made keeping in mind that when the therapist is needling the patient, the concentration should be and the efforts should be focused on the patient and not on this piece of paper. So many things are written so that you have to write less. Otherwise, when we are taking an assessment, most of the time it is a verbal assessment and we tend to forget. So there is so many things that are mentioned so that you do not lose out, you do not leave any significant amount of data. So let me explain different parts of this form one by one, and I would expect that if you are a needler, you'll be using this form next time, every time you needle, because as you can see, multiple segments makes it super easy to make your decision, and also super easy to document, so that tomorrow if the patient gets some problem, then you can say that this were the problem, and I had taken precautions, and I had taken this, or during my needling these things have come up, so that you are safe. So documentation is important, and there is a nice joke on the internet about a doctor saying the importance of documentation when he is confronted with specifically say jittery patient or whatever. Anyway, so what are the components of dry needling assessment form? Are 15 actually. There are 15 sections. The first section is related to the aim of needling. Why do you want to needle? Second section is related to patient's interview. The third section is related to contraindication. Fourth section is if there is any contraindication, you have taken enough precautions or not. Fifth section is related to the education of the patient, and how do you inform, what do you inform the patient before needling. Sixth section is related to the eligibility of the patient, and section 7 to 15 is related to the process of needling, recording of actual needling process. Let me go through them one by one, so that tomorrow if you want to needle your patient, you use this form and you use this step by step approach. So this is all step by step approach. and that is why the needling not only becomes easy, needling, making decisions related to needling becomes easy, as well as what will happen is, if I have needled a patient today and I'm handing over the patient tomorrow, always happens in an area where many physiotherapists work in shifts. Then looking at the chart, you will know that what has been done and what worked and what did not. So along with this, what you have is a body chart, and I am not going to tell you how to fill a body chart, you know better than me. But the body chart is extremely important here, because a lot of indication of needle is trigger point, and if you can mark the body chart properly, then you can understand that if the patient is having some issue with the trigger point or not, and what structure probably is involved, because a lot of time trigger points have their specific characteristic radiation pattern, sometimes not no like sometimes they do not follow a typical characteristic pattern, but sometimes we get lucky. Also, if you are filling the body chart, if you are drawing the body chart, preferably use a pencil and show the patient that this is the body chart, and are you happy with the representation of your pain. Then the section 1 is related to the aim of needling. Why do you want to needle? Your aim of needling is very important, because again, that Rambo picture, you don't want to shoot indiscriminate needle to the patient's body and hope that they will find a target. So I have mentioned three very important, or three most common types of needling, or three common aims of needling, which is analgesia, healing, and trigger point. But then you may want to decide to needle for other purposes as well. This is not completely exhaustive. So you may want to needle the patient for say spasticity as well, or scar tissue, or any other reason where you feel the needling is important. So then the D section, then otherwise you just stick, or you want to mention why do you want to needle. The section 2 is related to the interview, where you want to know important history related to previous incidents of needling. In this section, you ask the patient if the patient has prior experience with dry needle. Why this is important? Because then the patient knows, then you don't have to explain in the explanation section, or you still have to explain, but you will make that session a little shorter. So if the patient had an experience, then also it helps you to understand the baseline of the patient. So when the patient had taken needling, why the patient had taken needling, and what had been the response. If the patient's response can be graded, then you know that the patient was like the needling had been successful with the patient. If the needling had been successful with the patient, then the patient is going to have more faith on needling, and there is more chance that the patient will cooperate better, and there is more chance that your needling will also be successful. It will also tell you how long did the session go. Then in the next section, you are looking at contraindications, and it is important, because if it is contraindicated, you don't want to needle, or you need to take mandatory precautions if it is a relative contraindication. And what are the contraindications we are looking at? If it is not there, then only you are going to tick at none. So you list out, or you try to find out from patient's medical record if the patient has all these contraindications. And we had talked about contraindications of dry needling before, in the second session itself on the 17th of May. So I'll not go into much detail of the consent part or previous reaction part, but if you observe carefully, certain contraindications here are having dotted line next to it. So you are expected to not only tick here, but you are expected to give reasons, or you are expected to fill in more details. So if the patient is on anticoagulant therapy, you should write what and how much. If the patient has bleeding disorder, you need to mention. If the patient has a systemic or local infection, what infection you need to mention. Fever means how many days and what is the present grade of fever and why. Diabetes, again, it is important to mention if the patient has diabetes, not only put a tick, but also how severe it is and for how many years the patient is having diabetes. Because if you see the patient population, it is important to know the patient's present blood glucose level, but it is also important to know since how many years the patient is suffering from diabetes. Because you must have seen patients whose present sugar level is not much and the sugar is in control, but because the patient is having diabetes for a long time, the patient is still showing symptoms. And then if the patient is having immunodeficiency or the patient is under immunosuppressant, then you'll have to mention. The other contraindications are related to pregnancy, and if the patient is pregnant, then you have to mention more details, how many weeks and all this. Lymphedema, paresthesia, open wound, altered skin texture, hematoma, osteosynthesis is if the patient is having uh, fracture healing. Don't want to needle there. Don't want to meddle with the healing process. Joint replacement, if the patient is having joint replacement, you will have to ensure whether it is replacement or implants. They are all uh, relative contraindications, so you don't want to go into those areas. Pacemaker, metal allergy, COPD, epilepsy, valvular disorder, frail patient, and if there is anything else, kindly mention. So this is the section related to the contraindication. The next section talks about precaution. So what are the precautions you have taken? Primarily what you need to do is, if you find any relative contraindication, you need to call up the physician, inform the physician, take the opinion of the physician, and then if only he gives you go ahead green signal, then only you should needle. This is important because then it becomes a shared responsibility. Otherwise, again, you are not a dry needling therapist, you are a physiotherapist, you have so many other ways to needle the patient. Then you take the INR, which is an indication of the time that it takes for the patient's blood to clot. INR value normal is between, say, INR is about 1.1. People who are on thrombolytics or people who are on, say, warfarin or any other drug that affects the clotting mechanism is usually having INR between, say, 2 to 3. But if the INR value is available and if it is beyond normal, it is important for you to take a medical opinion before needling the patient. Then the fifth section is to educate or inform the patient. So that if you come here, as you can see, the fifth section is this, to educate or inform. What you are looking at is, before you take the consent of the patient, you must tell the patient what to expect. Now please understand that in many places the information and consent is only on paper, and sometimes it is not on paper as well, but this is extremely important. In my personal experience, sometimes it has happened that one of my dear family member has undergone a surgery, and just before the patient goes into the operation theater, I had been asked to sign a piece of paper without explaining anything. That should not be the case. You must be explaining what to expect from the patient. The benefits are twofold. Once the patient knows what is going to happen, the patient is going to cooperate better, no ugly surprises. And second, the researchers and psychologists says, researchers in behavioral economics says that if you explain the patient the benefits, the results are better. So you want to explain why are you going to needle, the purpose. You want to explain what are you going to do, that is the technique that is you are going to use. Then what are the benefits that the patient can expect out of needling. what are the equipments that you are going to use. Sometimes you may need to show the needle. What is the amount of exposure that you need? If you are needling the patient in the intimate area around the chest wall, around the groin area, the patient around the buttocks, the patient must know how much exposure is necessary. Otherwise, you have readied everything, and then you tell the patient that now I want to needle in your groin area, for example, for erector longus, and the patient says, no, I'm not very comfortable exposing that part. Then you waste your time and you waste patient's time also. So you must ensure that how much of exposure is necessary, that is clearly communicated. Then the expected sensations, what the patient is going to expect, is important. And then the reactions, what can happen because of the needle, during the needle is in the body, and after the needle is removed from the body, potential adverse effects. Then the patient has right to stop at any time, that you need to inform the patient. General activity guidelines, identification of adverse effects, for example pneumothorax, and what to do if adverse effects appear. So because we may miss out on any of the points, I have mentioned all these points from A to L in the form itself. So at a glance at the form, and you'll be able to explain all this without missing out on anything. And then only you take the consent of the patient after explaining everything. If the patient gives consent, ideally you should be taking the consent on a consent form. If you need a dry needling specific consent form, ping me up and I can forward you the PDF. And once the patient gives consent, the section 7 to 15 is related to the needling. So if you come here, you can see the section 7 to 15 here, which is from here to here. You can needle multiple structures, or you can use this form for multiple sessions. And the section 7 is related to the structure area you are needling. For example, upper trapezius. So you must understand that we are needling for a goal. So if you are needling, you must mention what is the pre-pain or symptom. Whether it is the pain, whether it is range of motion, whether it is the other things that you are looking at, say referred pain or the tenderness, that has to be mentioned. If it is pain, use a numerical rating scale, say 8 by 10. If it is range of motion, then use the degrees. So the pre-pain or symptom has to be mentioned. And then the next section talks about what are the local precautions and vulnerable structures. For upper trapezius, it is pleura or lung. Say you are needling the extensor carpi radialis brevis, it will be the radial nerve. If you are needling the biceps, you are looking at, say, the brachial artery. So these are the local precautions or vulnerable structures. Why this is important is because, again, studies in behavioral economics have clearly shown that if you remind yourself of something before you behave, before you make an action, it affects your action significantly. One of my most favorite book is called Predictably Irrational by Dan Ariely. And in that book, he has shown that MIT graduates, when they were taking a test and they were allowed to cheat, one set of people have been asked to remind themselves of 10 commandments, and another set of people, they didn't do anything like this. So the people who have reminded themselves in a completely unrelated incident, but just before the examination of 10 commandments, they did not cheat. Similarly, if you remind yourself of the surface anatomy in that area, if you remind yourself of the local precautions, you have more chance of taking extra care. Then the patient's position you must clearly mention, at least supine lying, side lying, prone lying, side lying with knee bent, or local area. If you're kneeling around the elbow isn't bent, like flexion or extension or whatever. Then what specific techniques that you are using? I will come back to the technique later. Then you are talking about the needle size and number, very important. How many needle you have used? what was the size of your needle, whether it is 25 millimeter, 40 millimeter, 50, 60 millimeter, 13 millimeter. So you must mention what is the size of the needle and how many needles you have used, and then how long you have kept the needle, the duration of the needling. Then post pain or symptom, that is after you have removed the needle, after the patient has settled down, what is the patient's symptom. Now if you are needling for pain, you must expect certain amount of analgesia, usually at least 2 scales down in the numerical rating scale to say your treatment has been effective. Again, if the range of motion has to improve, or if the patient was unable to do a function, you can do a comparable sign a la Maitland, or a functional. If the patient was unable to perform some function and you are able to give the patient that function, then that is also one acceptable way to find the difference between pre and post. And the last section is related to adverse effect reporting. If the patient has any adverse effect, whether it is a major adverse effect or a minor adverse effect. Then coming to the technique again here. Once you are talking about the technique, the form also mentions what are the techniques, common techniques that are usually implied, so that you can just use the shorthand of it. So it can be a superficial dry needling, you write SDN. If it is a deep dry needling, you write DDN. If it is the depth, how deep you have gone, approximately say 1 inch, half inch, or if you have used a 40 millimeter needle and 50% of 40 millimeter needle, that's it then. Angulation towards and away from. It's important at what angle you have inserted. And then if you have manipulated the needle, if you have done periosteal pegging, you have done needle rotation, you have done fishing, you have done pistoning, you have stimulated the needle to get more mechanical stimulation, or you have done a percutaneous electrical nerve stimulation. So anything and everything you can mention. So that in brief was how to assess and how to record a dry needling, a patient or a case where you are needling, dry needling. Please understand this form that I have shown you is an adjunct to your original assessment. This is not your basic musculoskeletal or neuromuscular assessment. This is as an adjunct. This is to help you with the process of needling. So when you are assessing the patient, please assess the patient beyond, actually before you treat the patient. Before you decide or take the dry needling assessment. This is just supplementary assessment, and if you are expert, then the whole process will take an extra 5 minutes, not more than that. That is also because so much of interaction is involved, because you need to explain things to the patient, you need to take consent, and that is why it should take 5 minutes. Otherwise your part will be within 2 minutes, it should be completed. Now that we have come to the end of this lecture series and this session, what is the road ahead? I have designed this lecture series so that I can create some inquisitiveness around needling, so that people are more aware of needling. People who had been asking question, or people who had been saying that needle doesn't work, or people who wanted to know how needle work. So that was an introduction in general, an overview of dry needling. If you are here, you have taken a 6-lecture series of dry needling, and you now have the capacity to understand dry needling and what it has to offer. Now what is the road ahead for you? You can decide to take a hands-on course, preferably from me. I will of course sell myself. So if you want to practice dry needling, it is absolutely important to take a hands-on course, and I would love to come to you and teach you. However, if you decide to take the course from another person, I cannot object, because it's a free country, and I will still extend my support. My dry needling 360 study materials and resources will always be open for you, whether you have taken a course from me or not. What you can also do is you can involve in research. I understand that many of you are in various grades of your BPT, whether you are a first sem or first year student or a final year student, or you are just trying to find a research topic in your PG or in your final year BPT. You can take dry needling as a topic of research to further probe. It is a very fertile field. A lot of work can be done with dry needling. If you have specific ideas, or if you want to know further related to research, you can ping me up and I will be able to help you, probably. Then you may want to keep yourself updated with dry needling literature, and if you are still a non-believer, then you can always debate about dry needling, and that debate will be an informed debate. That debate will not be that I am saying dry needling works or I am saying dry needling does not work. Now that you know that the proposed mechanisms and functions and the ways, you can fight with information. So these are the things that you can do, but don't keep yourself limited to all these also. You can always find more ways to utilize your knowledge related to dry needling, what you have gained from this specific course. So if you want to connect with me, you can hit me up with Facebook. That is, you can go into my page called Physilife, or you can connect me with my two profiles in Facebook. I have two because the first one is almost full. You can also mail me at physilife@yahoo.com. You can go to my website. If you are here, you must have gone through the study materials or the quizzes, so you know where is my website. That is physilife.in. Thus underscore Subhanjan is my Instagram handle, and you can WhatsApp me at 89675 Little bit of selling myself. So that is it. That's all I wanted to discuss in this season of dry needling 360. I hope this has been useful to you to some extent. I'm very thankful that so many people have come across, and so many people have taken this course, and it helped me in keeping myself occupied during this lockdown season. Otherwise, I would have just washed some utensils and slept the whole day, or watched Netflix or something. So thank you very much for being here. Thank you very much for keeping myself motivated. So many people have come forward and asked me questions, and stimulated me to think and come up with the answer. Thank you so much. Now I will scroll up and I will see the questions that have come. Give me a moment. Good afternoon. Yes, good afternoon, everyone. Hello and good afternoon is Mohammed Sadiq. Fantastic. You have got all 5 certificates. Very nice. People who did not get the certificate, understand this. This course is going to stay in the net. This course is going to stay in my website. So you can come to physilife.in and you can take the certificate. But one of my favorite quotes comes from Jeffrey Archer, where he says that only a fool comes to education to get a piece of paper. A wise person gets so much of knowledge and wisdom that he can handle any challenges that the world throws at him. So do not put too much of importance on the certificate. It's an auto-generated certificate. If you put your name, say as Gabbar Singh, then also the certificate will be generated. So I hope that you have got some more knowledge and understanding also from the course. Okay. Any more question? There is one question. Mohammed Sadiq says, does chronic condition have got cure while doing needling as well as some physiotherapy treatment? Yes, you can treat a lot of chronic conditions. However, and here I want to say this, that throughout your life as a clinician, your patients will come and tell that this patient was my cousin, my friend, my known people have been treated with some sort of therapy and they have got wonderful result. You will see advertisement saying that this person got this therapy and this person has got wonderful result. I see all the advertisements of growing hair in bald head and I see testimonies. Now understand this, testimonies are one of the ways to fool people. Do not look at testimonies, look at statistics. Because if I treat 100 people and one patient recovers without my treatment, even without my treatment or despite my treatment, I can put that person's picture, pay that person some money, and I can get a good testimony out of that. So please look at statistics. Please look at good quality research article before saying it works or not. It does not work. If you still want to look at testimony, look at my YouTube channel. I have put one patient's testimony because that case was very dear to me, and she kind of walked into our workshop crying with headache, and we treated her for 10 minutes and we were able to bring down her headache according to her 70%. So again, don't sell the testimonies, do not rely on the testimonies, look at the research article, right? So yes, dry needling, to answer your question, Sadiq, chronic conditions are cured or managed with dry needling. Dr. Tabish Ali is sleeping. All right. How long it will take to cure chronic scoliosis condition without surgery while doing chiropractic and physiotherapy treatment? Means, is it possible, sir? That is out of the scope of this discussion. Scoliosis is going to be different in different conditions, so you may have to uh, go for further details. Which position is good for trapezius muscle? Shruti, when I needle trapezius, I use supine position. It is much more safer in prone position. It is easy to visualize where is the lung, but you can get a high amount of twitch response by going through the anterior approach. Whatever way you want to go, whether you want to use an anterior approach or posterior approach, please stay away from lung. Please direct the needle laterally and superiorly. Good afternoon, good afternoon. Which position is better for upper limb needling? Depends upon the condition, depends upon the structure you want to needle. Some of the needling are there in my YouTube channel. You can look at that. Again, I'm selling my YouTube channel. Please, what's that word? Like, share, and subscribe my YouTube channel. Aishik Ghosh, what is the proportional of death in dry needle? Not many, not many. I don't have the statistics here. The statistics of death related to iatrogenic pneumothorax for acupuncture is very easily available on the net. But with needle, if you decide to kill someone, you can. But I'm yet to see a report of dry needling induced death. Okay, all of them are saying good afternoon, everyone. Will patient permanently relieve after taking dry needle? Depends upon the patient's condition. In certain conditions, you can create complete recovery in a single session of dry needling. Other conditions, if it is a chronic condition, if it is not treatable completely, then dry needling is going to produce temporary analgesia. So it depends on the condition. Shruti says if a mild prick brings about analgesic effects in the area, why it is important to insert needle deeply and take the risk of puncturing pleura? Would it be advisable for an amateur needler to go for SDN? Yes, you nailed it. Not only amateur needle, if you remember, a couple of times I have explained that the superficial dry needling was invented, or if I say discovered, by Peter Baldry because of this purpose only. So if you are around vulnerable structures, stay superficial. When in doubt, stay out. Superficial dry needling will give you analgesia. Anindo, hi Anindo, how are you? Says, in which month patient is not contraindicated to dry needle? In the month of patient's birth. I don't really understand. Sorry for the joke. I don't really understand the question. Are you asking about pregnancy? In that case, avoid the initial first trimester. More importantly, towards the end of full term. The second trimester is much more safer, and never needle a patient around the chest wall if you know the patient is pregnant, and you need to have a very compelling reason to needle the patient. Please tell more about INR. Okay, please tell more about INR full form, and should we go for a PT and PTT for every patient? No, not for every patient. You have to go for if the patient has higher risk. Now, if the patient has problem related to bleeding and clotting, many times you understand. You get to see the small petechial rashes or small red dot blotches on the patient's body. The patient will tell you the other histories, because in that case you don't have to you understand that the patient is having some problem related to bleeding and clotting. In take care, dry needling is contraindicated or not? It's not a fixed contraindication. You can treat the patient with TKR. I think it's almost. Wish you could needle my trapezius trigger points. Lala, come to Bangalore. I'll needle you. Rajesh. Okay. Thank you, Dr. Meena. As every day you have been very supportive. Someone who is so senior came here every day and attended this course. It's something that I will really cherish. Thank you so much. Is there any restrictions to practice wrangling in India by any regulation body? Very regulating body. Very pertinent question, Dr. Meena. As of now, nothing. As of now, there is no restriction, because as we insert the needle, there are many other people who insert the needle into the body. For example, a phlebotomist, a nursing practitioner, a tattoo artist. Everyone inserts needle into the patient's body. So there is, I don't foresee that this insertion of the needle into the, or someone who performs body piercing. So I don't foresee that inserting the needle into the patient's body will be banned for the physiotherapist in foreseeable future. Physiological mechanism dry needling does to the scar. Amos, go back to yesterday's talk. It's already 3 o'clock. I think if you have any more question, then just contact us in the WhatsApp group where you are, or if okay, I have stopped taking messages from the WhatsApp group because many people were leaving because of that problem, because so many people were disturbed being messaged. So you can just send me a direct message. Right after this, I am going to send the quiz within 4 o'clock for the first 4 groups, and we know how it comes in cascade. So the final quiz, the course completion, will take some more days. As in Sunday, I will send it because I'll have to create that quiz and create the system. So I'll finish it here. Thank you, everyone. Thank you for being here. It has been a wonderful experience for me. This is my first YouTube live and all this. I am learning a lot of technical expertise also with this. I may come back if time permits. I am hoping that I'll be able to keep something every month as a course like this. Please shower your appreciations and blessings like this again. Thank you so much. I'm Subhanjan from Physilife, signing out from Wrangling 360. It has been a pleasure. Have a nice day. Thank you.